Welcome back to the Mitochondriacs to another episode of Cancer as a Mitochondrial Metabolic Disease. Radiation therapy is one of the most common cancer treatments used today. But what if the effectiveness of radiation therapy depends on something as simple as oxygen? Many tumors are hypoxic, have low oxygen, and that low oxygen environment can make radiation therapy far less effective. In this video, we'll break down how radiation therapy works, why oxygen is critical for its effectiveness, and how tumor hypoxia can lead to radiation resistance. So without further ado, let's get into it. Okay, so let's get into tumor oxygenation or tumor hypoxia part 4. This is going to be the final video on hypoxemia for tumors. So there was a paper published in January of 2024. It was titled Tumor Hypoxia and Radiotherapy, a Major Driver of Resistance Even for Novel Radiotherapy Modalities. And it says here, hypoxia in solid tumors is an important predictor of poor clinical outcomes to radiotherapy. Both physiochemical and biological processes contribute to a reduced sensitivity of hypoxic tumor cells to ionizing radiation and hypoxia-related treatment resistances. I'm also going to read the next sentence. A conventional low-dose fractionated radiotherapy regimen exploits iterative reoxygenation in between the individual fractions. Nevertheless, tumor hypoxia remains a major hurdle for successful treatment outcome. And I want to just reiterate and reorganize and reorient ourselves to what physioxia and what hypoxia actually represents. So this table has shown us that basically anywhere between about 30 to 50 millimeters of mercury is considered normal, although we have seen in other publications that in certain tissues like breast, 65 millimeters of mercury may be normal, which is above probably the 7.5%. And it can go maybe as low as 15 to 17 probably in the more hypoxic regions of bone normally. However, we've also established that there are different levels of hypoxia, and the lower the millimeters of mercury or the lower of percent oxygen is going to represent lower amounts of hypoxia. And we can say from many studies that most tumors, solid tumors, are going to be hypoxic at the level of about, on average, 10 millimeters of mercury, which is roughly, 1% oxygen. And we also know that given the tumor architecture, because of the poorly developed vessels that these cancer and tumors produce that are diseased and pathologic, they do not allow for oxygen to get into the deeper cores of the tumor where a lot of the cancer stem cells are at. And in those particular parts of the tumor, it may be as low as 0.1% oxygen and 0.7 millimeters of mercury, which is pretty much anoxic, no oxygen whatsoever. So those regions of the tumor are very, very hypoxic. So knowing this and reorienting ourselves, let's look at a couple of graphics that help us understand what's going on here. So this is a graphic from actually the first video that I copied down here because it's well known. I think we looked at some of the papers in the prior videos that this has been well known within radiation oncology for 75 years. So here is oxygen at 21%, 155 millimeters of mercury. Here's peripheral tissues, somewhere between 30 and maybe as high as 65 millimeters of mercury. And then here's the average tumor right here. And then we can see that if the average is lower, like some of the even average prostate or average, pancreatic is somewhere between 2 and 4 millimeters of mercury average. And then their hypoxic regions where all the cancer stem cells are going to be at, less than 1% and, probably like 1 millimeter of mercury of oxygen. You can see here how this is radiosensitivity, right? So this is physiologic tissues. And then once you start getting below physiologic oxygen amounts, this is millimeters of mercury, you hear 20, mild hypoxia, it's much less, or it's less effective than it is at physiologic oxygen. Then we start getting into what would be average for tumors, 10. Let's go up to here. Now we're a lot less sensitive to radiation. And then we get into the, the more hypoxic regions of the tumor cell, more hypoxic regions of the tumor, and it's much less effective. Here's what it's saying, that tumors, we looked at this previously, especially the hypoxic regions of tumors, are 3 times less radiosensitive compared to their normoxic counterparts. And why is that? So basically, here is a schematic of a tumor, right? So here we have it, depending on how purple it is more hypoxic, right? So the outer regions that have more kind of normal blood vessels are going to be less hypoxic. These are also the interestingly enough, the cells that are generally proliferating very rapidly and what chemo and radiation therapy generally have a lot more of an effect on due to mechanism of rapid growth, but also due to better oxygen status. And then the deeper we get into the tumor, the more disorganized and the more inability for oxygen to get deeper into these tissues. And you see the more purple that part of the tumor is for hypoxic regions. And you're going to see that those areas of where the stem cells are at, they're not as rapidly growing and they are going to be more resistant to therapies, not only because of mechanism, but also because of oxygen status. And then we shoot ionizing radiation here. And then that ionizing radiation is going to create massive amounts of reactive oxygen species, DNA damage, et cetera, et cetera. And so you see here, it kills off. See, this is dead tumor cells, hypoxic, normoxic, right? So it's going to kill off the normoxic tumor cells or the more normoxic tumor cells. It's still going to be on average lower than normal tissues, but it's still going to be more normoxic, right? It's going to be higher up on this curve, somewhere between here and here, maybe the more normoxic tumor cells. So it's more sensitive. But then what's left is the more hypoxic tumors that's not affected whatsoever by radiation therapy or minimally affected by radiation therapy. And that's where the tumor stem cells are at that have the, potential to metastasize and grow back. So you're killing off with chemotherapy and radiotherapy these more normoxic, rapidly proliferating cells. And then the hypoxic core is left intact a lot of times. And then reoxygenation happens. They shoot it again. Now we have supposedly more normoxic areas and you hit it again. And that's what the goal of these fractionations is. And we're going to talk about fractionation specifically when it comes to photodynamic therapy, because it's also in play or in operation at that point too. Again, this is like another picture here where we're looking at, we're shooting radiation under normoxic conditions, more ROS is made and, DNA is terminally damaged. So that way these cancer cells are supposedly going to die completely. Whereas if there's hypoxia, you shoot DNA, there's less ROS made, so there's less DNA damage, and then there's more chance for, a poor outcome. Here in 2021, there was a paper published called Interfering with Tumor Hypoxia for Radiotherapy Optimization. And it says, hypoxia in solid tumors is an important predictor of treatment resistance and poor clinical outcome. The significance of hypoxia in development of resistance to radiotherapy has been recognized for decades, and the search for hypoxia targeting radiosensitizing agents continue. And, I was surprised. I'm not going to go through all these because they're just kind of like one and the same. But I think that when I saw, where was it? This particular graphic here, this is actually one of the first graphics that I saw after I had a conversation with Dom D'Agostino, because he's the one who actually led me onto this. And so basically these kind of graphics, and this is very well known within radiation oncology for a long time. Here's physiologic physioxia, right? 30 to 60 is up here, right? And then when you get to 15, really maybe 12, then you're going from radiosensitive to radioresistant. And if you have to understand that the average is 10. So it's already known that these cancer cells are going to be resistant. So you end up having to shoot more and more radiation to try to get a desired effect when you're going to have side effects of that potentially to the surrounding normal tissue, or you're going to have diminishing return or radiation resistance. And then we get down into the more hypoxic regions of the cell, which we know occur, we know happen, and that's where the cancer stem cells are at. We know that they're going to have very little effect on those areas. Let's read some of this paper. So while long-term exposure to severe hypoxic conditions is lethal for many cells, subpopulations of tumor cells could adapt to hypoxic conditions and become resistant to radiotherapy, chemotherapy, and immunotherapy. One of the most studied resistance to therapy linked to tumor hypoxia is resistance to radiation therapy. The potential involvement of oxygen as a modulator of response to radiation was published already more than 100 years ago. G. Schwartz described the effect of hypoxia as a predictor for radiation in 1909. So we've now seen it, say, decades they've known about this. I heard in one paper that was 75 years. This paper is saying it's been known for 100 years. So probably around the same time, actually slightly earlier than Warburg. And we've known about metabolic reprogramming, glucose and et cetera, utilization by cancer cells. They've known that cancer is resistant to radiotherapy because of hypoxia for more than 100 years. He observed that skin compression and reduction of blood flow decreased the radiosensitivity, actually reduced radiation burn. About 70 years ago, the seminal studies of Gray and Tomlinson suggested that the importance of microregional structures and oxygen gradient for the response of irradiation, 1953-55 respectively. Since these early studies, several thousands of manuscripts have been published on the thematic research, 8,321 references on PubMed relating to hypoxia and radiation. The mechanism responsible for the enhancement of radiation damage by oxygen is generally referred to as oxygen fixation hypothesis. DNA is generally considered the ultimate target, leading to mitotic catastrophe. Damages to DNA may be produced directly or indirectly through the water radiolysis and production of highly reactive free radicals, which ultimately produced in DNA a transient radical R from RH. When oxygen is present, RH can immediately react with oxygen to produce ROO and further produce ROOH. In other words, oxygen is fixing the DNA damage with a change in the chemical structure of DNA. The absence of oxygen, the unstable R molecules have a longer half-life and can react with H, thus chemically restoring their original form. The oxygen enhancement ratio, OER, the ratio of doses required to obtain the same survival under hypoxic or anoxic conditions, varies from 2.5 to 3, indicating that hypoxic tumor cells will require 2.5 to 3 times higher dose of radiation to be killed than normoxic cells. This is actually pretty astounding, because if they were able to fix the hypoxia in these tumor cells before radiation therapy or during radiation therapy, we could use 2.5 to 3 times less radiation compared to what we're having to use because we're not addressing this. From literature, it appears that OER, oxygen enhancement ratio, is dramatically increasing when PO2 is rising from 1 to 10 millimeters of mercury. Above the value of 10 millimeters of mercury, further increase in oxygen does not further enhance radiosensitivity. The effect of tumor hypoxia on the response to treatment by ionizing radiation has been demonstrated in a multitude of experimental preclinical studies. In a series of clinical studies in the early 90s using PO2 measurements with microelectrodes, Volpel and others definitively demonstrated that tumor hypoxia was predicting the response of tumors to radiation therapy. Although tumor hypoxia is acknowledged as a major factor of resistance of solid tumors to radiation therapy, the clinical practice actually does not yet fully integrate on a routine basis this factor in the definition of radiation protocols. Possible strategies for improving the curative effect of radiation therapy on hypoxic cells include the alleviation of tumor hypoxia at the time of radiation and/or redistribution of the radiation dose, integrating presence of hypoxic areas. From a meta-analysis gathering 10,108 patients from 86 different randomized clinical trials designed to modify tumor hypoxia in patients treated with curative attempted primary radiation, Overgaard concluded that ample data exists to support high levels of evidence for the benefit of hypoxic modification. However, hypoxic modification still has no impact on general clinical practice. In a second meta-analysis, he analyzed that the results from clinical trials that included 4,805 patients suffering from squamous cell carcinoma of the head and neck with attempts to modify the hypoxic radioresistance by applying normobaric oxygen, carbogen breathing, hyperbaric oxygen, or hypoxic radiosensitizers. Again, he demonstrated the added value of adding hypoxic modification to radiotherapy in head and neck squamous cell carcinoma patients. In discussing the results from these meta-analyses, Overgaard pointed that the lack of proper identification of patients with hypoxic tumors required adapted treatment was an obstacle to routine clinical use of hypoxic targeted interventions. So basically, we've known about this for 100 years. They realized that if you modify the hypoxic environment, there's better clinical outcomes with radiation therapy specifically. But because they're not able to figure out who has a hypoxic tumor, it's leading to an obstacle to routine clinical use. This seems like BS, because basically we know that all tumors are hypoxic, at least more often than not, 3x compared to physioxia. And maybe we don't know the exact amount of hypoxia for that particular tumor, but at least a big portion of the more hypoxic, poorly vascularized regions are going to be hypoxic. So therefore, do we even need to identify the patients with hypoxic tumors before we let this obstacle keep us from using clinical tools at our disposal to relieve tumor hypoxia if we're going to use these radiation therapies, so that we can either have more time, more benefit, or less radiation dose per therapy? So we're seeing, just like the hyperutilization of glucose discovered by Warburg more than 100 years ago has been well known within the medical literature, we're now seeing that hypoxia has been well known in the medical literature for more than 100 years. And we know that the medical literature and researchers have known that hypoxia is the limiting factor to treatment success versus failure for both chemotherapy and radiotherapy, and more novelly, immunotherapies. Yet, still 100 years later, it's not being addressed. I can imagine that you are also as frustrated as I am when I'm reading these slides and I'm realizing that clinically we're doing nothing about this. If you like videos like this, please like, share, and subscribe. And until next time.